Good morning, everyone. Today's topic is assessment of aortic valve disease by transesophageal echocardiography. First, we will discuss the echocardiographic evaluation of aortic stenosis. The characteristic of aortic stenosis on 2D echocardiography is aortic leaflet and significant aortic stenosis are usually thickened, echogenic, and calcified. In rheumatic aortic stenosis, calcification occurs along the free edge of the cusp and commissures as opposed to degenerative aortic stenosis, where calcification is most prominent at the base of the cusp. In mid-esophageal AV long axis view, valve cusp should appear as two thin parallel lines that lie close to the wall of aorta. An important sign of aortic stenosis is leaflet doming during systole, in which leaflets are curved toward the midline of the aorta instead parallel to the aortic valve. As you can see in this figure, first figure where you can see the leaflets are open parallel to the wall of the aorta. In second figure, you can see the leaflets are thickened and it curved toward the midline instead parallel to the wall of the aorta. Apart from that, leaflet separation less than 8 mm has 100% predictive value of diagnosing moderate to severe aortic stenosis. Alveolar hypertrophy is an invariable feature of aortic stenosis and is usually associated with the diastolic dysfunction. Other features that may be associated with aortic stenosis is post-stenotic dilatation. AR, aortic regurgitation, may also be present as extensive calcification prevents complete closure of valve in the diastole. There are the two main techniques for determination of the severity of aortic stenosis. One is calculating the calculation of aortic valve area, and second is calculation of peak or mean gradient using the modified Bernoulli equation. Aortic valve area can be calculated by 2D planimetry or Doppler derived measurement of the aortic valve area. First, we will discuss the 2D measurement of the aortic valve area. Normal aortic valve area is 3 to 4 cm square, and it is commonly measured with the planimetry tracing of aortic valve orifice in mid-esophageal AV short axis view during systole. While measuring the aortic valve area with planimetry, we have to ensure that the cross section is of leaflet edges. If the cross section is oblique or inferior to leaflet tips, then it can overestimate the aortic valve area. As you can see in this figure, there is the various cross section of the aortic valve orifice. So, the solid line indicate the true cross section which occur at the leaflet tips. If there is the cross section below the leaflet tips, or if there is the oblique cross section, then it can overestimate the aortic valve area. In true AV short axis view, aortic valve appears circular and all three cusps appear equal in shape. To locate the actual orifice, first we should get mid-esophageal AV long axis view to identify smallest orifice at leaflet tips, and then orifice is centered on image display, and then multiplane angle is rotated to short axis view. The limitation of this technique are leaflet edges are difficult to identify if valve is heavily calcified or presence of pinhole edge in which valve orifice cannot be identified. The second technique for calculation or measurement of aortic valve area by continuity equation. The principle of continuity equation describes the conservation of physical quantity, that is energy and mass. Blood flow in one portion of the heart must be equal to the blood flow in another portion of heart. This application of continuity equation is commonly used to calculate the aortic valve area. In this case, it is assumed that blood flow across the LVOT must equal flow across the aortic valve. As we already discussed, LVOT blood flow is equal to aortic valve blood flow. So, to calculate the LVOT blood flow, we have to measure the LVOT area and LVOT velocity. And for calculation of aortic valve blood flow, we have to measure the aortic valve area and aortic valve velocity. As we want to measure the aortic valve area, so this equation again rearrange, and it is like LVOT area multiplied with the LVOT velocity upon the aortic valve velocity. By this equation, we can measure the aortic valve area. LVOT diameter is measured in mid-esophageal AV long axis view from inner edge of AML to inner edge of the septal endocardium in mid-systole within 0.5 to 1 centimeter of aortic valve orifice. Applying this formula for the area of circle is equal to pi radius square. Pi radius is square, and this pi radius is square is equal to pi radius is equal to diameter upon 2 square. So, area is equal to 0.785 into multiply with the diameter square. Using either a deep transgastric or transgastric long axis view, the Doppler spectrum of the aortic valve and the LVOT is displayed. The LVOT is measured, LVOT velocity is measured with the pulse wave Doppler and sample volume position approximately 5 mm beneath the aortic valve. Blood flow velocity across the aortic valve can then be obtained with the continuous wave Doppler. Here you can see in this figure, the figure A is showing the continuous wave Doppler across the aortic valve and shows the high velocity. The figure B is showing the pulse wave Doppler in the LVOT, and the figure C is showing the LVOT diameter, that is 0.5 to 1 centimeter below the aortic valve. So, by this we can measure the aortic valve velocity, LVOT velocity and the LVOT diameter, and thus we can calculate the aortic valve area. Commonest error in using continuity equation to measure the aortic valve area is error in measurement of the LVOT diameter. As LVOT diameter is squared, so a small error will be magnified in calculation of the aortic valve area. Second error is underestimation of the peak aortic valve velocity due to failure to interrogate the highest velocity part of systolic flow through the stenotic valve. Another method or second method for determination of aortic stenosis severity is calculation of the peak or mean gradient using the modified Bernoulli equation. Doppler echocardiography is used to quantitate aortic stenosis by measurement of blood velocity across the aortic valve and determining the pressure gradient using modified Bernoulli equation. For measuring the velocity, mid-esophageal long axis view is not suitable. So, we use the deep transgastric or transgastric long axis view to measure blood flow velocity across the aortic valve, because in both these view the blood flow is parallel with the Doppler beam. This figure is showing the continuous wave spectral Doppler display of velocity through the stenotic aortic valve, and it shows the fine feathery appearance of high velocities in mid-systole, which indicate the flow across the stenotic aortic valve. So, by this we measure the velocity, and then we put this velocity in modified Bernoulli equation, and thus we get the pressure gradient. Normal aortic valve have peak velocity of 0.9 to 1.7 meter per second, and peak usually occur in the early systole. Now, coming to the Doppler pressure gradient versus cardiac catheterization. Doppler derived gradient differ from the gradient obtained in the cath lab, and this difference is because of different technique employed for the gradient determination. Doppler derived measurement correspond to the instantaneous gradient, while pullback technique of catheter from aorta to LV during cardiac catheterization represent peak to peak systolic pressure difference. Peak to peak gradient in cath lab is often lower than instantaneous gradient obtained with Doppler, and this difference because of pressure recovery effect. Now, what is the pressure recovery effect? So, when blood flow through the stenotic orifice, the potential energy will converted into the kinetic energy. So, you can see here in this figure, when the blood flow passes through the stenotic orifice, the pressure will drop. Now, what happened? The downstream of vena contracta or effective orifice area, the large portion of this kinetic energy will dissipate it as heat, and the remaining portion of the kinetic energy will reconverted into the potential energy, and again pressure will increase it. This is called the pressure recovery effect. Measured Doppler gradient. So, measured Doppler gradient can correspond to the invasively measured gradient if catheter positioned at the level of vena contracta or effective orifice area. However, the catheter is frequently positioned in ascending aorta rather than at the level of vena contracta. There are certain limitations to assessing the severity of AS by transvalvular velocity. any condition which can reduce the transvalvular flow, such as severe LV dysfunction, severe MR, low cardiac output, left to right endocardial shunt, so it will reduce the pressure gradient. And condition which increases the transvalvular flow, such as hyperdynamic LV, sepsis, hypothyroidism, it will increase the pressure gradient. This table is showing the summary of aortic stenosis. So, if aortic jet velocity is between 2.6 to 2.9 meter per second, then it is suggestive of mild aortic stenosis, and if it is more than 4, suggestive of severe aortic stenosis. If the mean gradient is less than 20 millimeter mercury, mild AS. If it is more than 40, severe AS. Aortic valve area is more than if it is more than 1.5 centimeter square, suggestive of mild aortic stenosis, and if it is less than 1 centimeter square, suggestive of severe AS. If index aortic valve area is less than 0.6 centimeter square per meter square, suggestive of severe aortic stenosis. Now coming to the echocardiographic assessment of the aortic regurgitation. This table is showing the classification of the aortic regurgitation. So there are the 3 types of aortic regurgitation. Type 1 where the AR is because of enlarged aortic root with the normal cusp, and echocardiographic findings are aortic root dilatation with retraction of the aortic valve leaflet. Type 2 AR is because of either cusp prolapse or cusp fenestration. Cusp prolapse are further divided into 3 types: cusp flail, partial cusp prolapse, and the whole cusp prolapse. Cusp flail is said when there is a complete eversion of the cusp into the alveoli in long axis view. Partial cusp prolapse is because of is partial cusp prolapse when there is a distal part of the cusp prolapsing into the alveoli, and whole cusp prolapse when there is a free edge of the cusp overriding the plane of aortic annulus and with the billowing of entire cusp body into the alveoli. Type 2B AR because of the cusp fenestration, and type 3 AR because of poor cusp tissue quality or quantity. Although 2D echocardiography is used to determine etiology of AR by identifying structural abnormalities of leaflet or aortic root, however, it is not useful for quantifying the severity of AR. There are several associated echocardiographic features seen in the aortic regurgitation, such as dilated LV, and LV is more spherical in shape. Eccentric AR jet directed toward the anterior mitral leaflet that may cause doming of AML with the convexity toward the left atrial side. So here you can see in this figure, this is the mid-esophageal AV long axis view with the color flow Doppler showing the flow turbulence across the aortic valve, and there is the eccentric AR jet directed toward the anterior mitral leaflet. So the first technique for assessment of the severity of AR is by color flow Doppler. And this color flow Doppler it's the most sensitive means to detect the aortic regurgitation, and the best views are mid-esophageal AV long axis view and the mid-esophageal long axis view. Mid-esophageal AV short axis view also useful to identify site, size, and the shape of the regurgitant orifice. In this view, by putting color, we can measure the jet width, and this jet width compared with the alveoli width. And this jet width and the alveoli width ratio correlate with the angiographic determinant of aortic regurgitation, and if this ratio is more than 0.65, then it is suggestive of severe AR. Length of AR jet into the receiving chamber does not correlate with the AR severity. This figure showing the transesophageal, mid-esophageal AV long axis view with the color flow Doppler. Here you can see the A indicates the alveoli width and the B is the jet width. So by this we can calculate the jet width and the alveoli ratio. If this ratio is more than 0.63, like in this patient, suggestive of the severe AR. In mid-esophageal AV long axis view, we can also measure the vena contracta. Now, what is the vena contracta? Vena contracta is the narrowest portion of the regurgitant jet at the level of aortic valve. So, despite the simplicity of the vena contracta measurement, there are the few limitations. If there is a multiple or abnormally shaped regurgitant jet, then it affects the reliability, then it affects the vena contracta reliability for determination of AR severity, or inability to accurately determine the annular plane of aortic valve due to the pathology. This table is showing the limitation of estimating AR severity with the color flow Doppler. So, any condition such as mitral annular calcification or prosthetic mitral or aortic valve will shadowing the LVOT. So, that will lead to inability to image the LVOT. Or if there is regurgitant orifice is asymmetric, then it will in that condition AR jet is wider in one plane. AR jet appear wider in one plane versus another plane. So, it will lead to inaccurate estimate of AR jet width and the vena contracta. And if there is any leaflet prolapse, then that will lead to eccentric jet and AR jet appear wider than the orifice size. The second technique for determination of AR severity is continuous wave Doppler. Here, by using the continuous wave Doppler, we measure the deceleration slope of regurgitant jet and calculate the pressure half time. Now, what is the pressure half time? It is the time required for the peak regurgitant pressure to decrease to half of its maximum value. For calculating pressure half time, we use the deep transgastric long axis view or transgastric long axis view because it aligns the regurgitant jet with the Doppler wave. You can see in this figure there is an association between the LVOT velocity and the pressure between aorta and the LV. In patient with the severe aortic insufficiency, the deceleration slope is steeper, and it is because of pressure between the LV and the aorta is rapidly equilibrate. Limitation to estimating the severity of AR using the deceleration slope are first is increase SVR. Any condition which increase the SVR will lead to steeper slope, and here we can overestimate the aortic regurgitation. Condition which reduce the LV compliance, such as due to the myocardial ischemia or cardiomyopathy, will again lead to steeper slope, and here we can overestimate the AR. And if there is eccentric jet, that will also in that condition we cannot use pressure half time or deceleration slope. The third technique for determining the AR severity is pulse wave Doppler. Pulse wave Doppler is used to detect retrograde flow in the aorta during diastole. Hollow diastolic blood flow in abdominal aorta is sensitive and specific for severe AR, and while the hollow diastolic blood flow in the proximal descending aorta is a sensitive indicator of AR, but it is not specific for the severe AR. This figure is showing the pulse wave Doppler velocity of in descending thoracic aorta. So, you can see in during the whole diastole blood flow, retrograde flow occur, and it is associated with the severe AR. Another method for quantifying the AR severity is regurgitant fraction. Regurgitant fraction is regurgitant flow divided by the aortic outflow. Regurgitant flow is determined as the difference between the aortic flow and a reference flow across a competent valve, either pulmonary or mitral valve. Calculate the aortic valve systolic flow using the LVOT. So, flow is equal to LVOT area into the LVOT VTI. So, LVOT VTI is measured in the deep transgastric and the deep transgastric view, and the LVOT diameter can be obtained in mid-esophageal AV long axis view. To calculate the pulmonary systolic flow, we measure the pulmonary artery diameter and the pulmonary and the VTI of the valve that can be obtained from the mid-esophageal ascending aorta short axis view. So, regurgitant volume is equal to aortic systolic flow minus the pulmonary flow, and by this we can measure the regurgitant fraction, which is equal to regurgitant volume upon the aortic systolic flow. Pitfalls of regurgitant fraction. The first is it is time consuming. It may distract anesthetist from patient care and the monitoring. And the second is measurement of stroke volume across mitral or pulmonary and the aortic valve should be done under the same hemodynamic conditions. As this measurement are obtained sequentially, rapid transient changes occurring during the anesthesia. Effective regurgitant orifice continuity equation could be theoretically used to determine the regurgitant orifice size. So, effective regurgitant orifice area is equal to aortic root area multiplied with the aortic root diastolic VTI upon the aortic valve regurgitation jet VTI. This technique has not been widely accepted. This table is showing the quantification of aortic regurgitation. So, if pressure uptime is more than 500 milliseconds, suggestive of mild AR. If it is less than 200, suggestive of severe AR. If vena contracta is less than 0.3, mild AR. If it is more than 0.6, severe AR. And jet width, LVT width less than 25%, mild. If it is more than 65, severe AR. And regurgitant fraction is less than 30%, mild AR. If it is more than 50, so severe AR.